Welcome. It's 4 o'clock and we're starting our ESVS and EWMA joint webinar. It's wonderful to be here this afternoon with you all. My name is Melina Vera. I'm a vascular surgeon from the north of Spain and a member of ESVS. I'm actually editor-in-chief of the ESVS second journal, Vascular Forum. And it's really a pleasure to be sharing this next hour and a half with all of you and with our panelists. This is really a very important topic, and we're going to try to give a 360-degree view, because multidisciplinary approach is key in the successful treatment of patients with wounds. So on behalf of myself and ESVS, I'm really happy and proud to be co-hosting and participating in this joint webinar with EWMA. And I'm co-hosting this webinar with Kirsi.
Thank you, Melina. It's a pleasure to co-host this webinar with you. And we also find this item about lower leg ulcer diagnostics and treatment very important, and it is one of the focus areas that EWMA has been focusing in the recent years as well. And I would like to ask Amalie from EWMA Secretariat to say the slides, the promotion slide of our new document. EWMA has published a document on lower leg ulcer diagnostics and principles of treatment recently, and it is freely downloaded from the EWMA website, and it is published in the Journal of Wound Management. And the next slide, please. Here you can see the author group that was really multidisciplinary, with from different disciplines, from physicians and tissue viability nurse experts, and around the globe we had Hayley Ryan, for instance, from Australia, and a representation from many European countries as well. And here in this webinar we will be hearing Eva Stürmer, that was the main author of the wound infection chapter in that document. And the last slide, please. One deliverable of this document was this one-pager. We hope that you could look into and perhaps take into your clinical practice also. It is about the simple diagnostics of wounds, especially I think would be beneficial in primary care setting. With every patient with wound, you should think excluding about the 3 I's: infection, ischemia, insulin, that is diabetes mellitus. Those are the most acute and most important reasons behind a wound. But after that, you should think also about ATP, atypical signs, distension and edema, and pressure injury. These 6 things should be taken into account with every wound patient. And then lastly, but not least, PPL, the peri-wound skin, that is often neglected. The patient-reported outcomes, very important: pain, quality of life, and also the local treatment. So this can be found also at our EWMA website. But now I will be happy to hand over to Melina again, who will introduce our first speaker.
Well, our first speaker is Marit Venermo. She is Secretary General of ESVS, as well as head of the Vascular Surgery Department, the Hospital of Helsinki. And she's going to talk about one of the key I's that you just mentioned in that poster. And that's the assessment of perfusion, which is one of the first things we should look at assessing any lower limb wound, isn't it, Marit?
Absolutely. Thank you, Melina, for the introduction. And I will now share my slides. Can you see them? No?
Not yet. Give us a second.
Now we can see them.
Yeah, there they go.
Excellent, thank you. So I will talk about perfusion assessment of a leg with an ulcer. And I'm very happy to be in this joint session, and I thank Kirsi about the initiative to build this joint webinar. So no disclosures related to this subject. We have also another document which was published very lately, and it's joint guidelines on peripheral artery disease in people with diabetes and food ulcer. And I refer in my talk some chapters in these guidelines because I think that regarding perfusion assessment, it's valid also in patients with food ulcer and no diabetes. So first, a little bit about background. Assessment of food perfusion is a vital step in the management of patients with food ulcer. And why? To understand the risk of amputation, to understand likelihood of wound healing, and to measure increase in perfusion after possible revascularization. Underlying PAD is a common finding in patients with food ulcer and is associated with poor outcomes. Thus, assessment of food perfusion should focus on underlying the presence of PAD and to subsequently estimate the effect of this may have on wound healing. Early and adequate assessment of food perfusion is necessary to ensure that the elevated risk of delayed or poor wound healing and amputation are identified early so that they can be addressed without treatment delay. The first step in the patient's examination aiming to understand the level of arterial circulation is pulse palpation. However, it has very small ability to identify or exclude peripheral arterial disease. And pulse palpation should be seen as the first step in a systematic evaluation of the affected limb and foot, but further diagnostic procedures should be performed with non-invasive bedside techniques, as clinical examination is not sufficient to exclude PAD. So the second step is to use bedside testing techniques that provide objective measurement of peripheral blood flow in lower extremity. And this means ABI, toe pressure, TBI, and pedal Doppler waveforms. And in the guidelines I just presented, there is a recommendation evaluate pedal Doppler waveforms in combination with ABI and TBI measurements to identify the presence of PAD. And these measurements are useful as means to rule PAD out or in for people who are suspected of having PAD. In Helsinki University Hospital Vascular Laboratory, we use handheld Doppler. We measure ABI, toe pressure, PVR, TCPO2. We use duplex ultrasound as well as in some patients in designing green fluorescence imaging. Well, the basic measurement is ABI. It's mobile, it's cheap, it's available. And if ankle pressure is lower than brachial pressure, stenosis in artery is likely, which means ankle brachial index is less than 0.9. And usually from 1 to 1.3, it's normal value, or the arterial blood flow should be normal. If it's less than 0.6, wounds doesn't heal. If it's less than 0.5, in 95% of the cases, there's multi-level occlusive disease, and less than 0.3, there is gangrene or rest pain. This is not this easy because many patients who have ulcer, especially if patients also have diabetes, there is medial sclerosis. And this is from the material in Helsinki University Hospital. These are patients who have visited our outpatient clinic in order to assess food perfusion. And there were altogether 6,000 patients, and 650 patients had normal ABI. And these are the patients who had normal ABI. And you can see toe pressures in these patients. So a quarter of the patients had toe pressure less than 50. And when we compare the mortality, this you can see in this Kaplan-Meier curve 12-year mortality, and the green line are patients who had toe pressure less than 50 millimeter mercury, and the purple line is those that had toe pressure over 80, and we can see clear difference in mortality. And those patients who had toe pressure less than 50, the most of they died because of cardiovascular diseases. So it means that many patients who have normal ABI do have also PAD. So let's go back to the joint guidelines about the diabetic foot ulcer. It says no single modality has been shown to be optimal for diagnosis of PAD, and there is no value above which PAD can be excluded. PAD is more likely to be present in a population with ABI less than 0.9 or ABI over 1.3 or TBI less than 70, and presence of one or more monophasic Doppler waveforms. PAD is less likely in presence of ABI between 0.9 and 1.3 or TBI over 0.7 and triphasic or biphasic PDA Doppler waveforms. Any abnormal test result should be considered indicative of PAD. When we see a leg like this and we listen patient history of smoking, we can actually pretty much be sure that there is CLTI or there is insufficient arterial perfusion. But how about this patient? This is more tricky. No pulses. If ankle pressure is 70 millimeter mercury, ABI 0.5, we can say that yes, there is ischemia with impaired wound healing. How about if ankle pressure is 140, ABI 1.5? We cannot exclude PAD. Then we ask, does patient have diabetes or no? How about if ankle pressure is over 200? So then we need toe pressure and TCPO2. Toe pressure is more reliable than ABI because medial sclerosis usually does not affect toe arteries. It's needed in CLTI diagnostics, especially when patient has tissue lesion and if ABI is surprisingly good, or if patient has diabetes. Toe pressure is sensitive for temperature, coffee, and smoking. It's not available when patient doesn't have toes. And in Wi-Fi classification, if toe pressure is less than 60 millimeter mercury, there is ischemia, and if it's less than 30 millimeter mercury, it's critical ischemia. In Helsinki, we measure annually 7,000 ABI and toe pressure measurements and 250 TCPO2 measurements. Well, once we have diagnosed PAD, the second questions are how severe PAD is, does it impact on wound healing and increase risk of amputation? This will inform whether further investigation or intervention is required. Ankle pressure and ABI are weak predictors of healing. A low ankle pressure, like less than 50, or ABI less than 0.5 may be associated with impaired healing and greater likelihood of major amputation. And toe pressure over 30 increases probability of healing and less than 30 and increases probability of major amputation and decreases, of course, healing. If toe pressure cannot be performed, consider TCPO2 measurement or skin perfusion pressure to assess likelihood of healing. TCPO2 and SPP are additional tests that have the advantage of measuring perfusion at tissue level. We use TCPO2 mostly when we assess the level of minor amputation and wound healing capacity. And if TCPO2 is less than 10, usually wound does not heal. If it's between 10 and 30, the healing is unsure and impaired. If it's over 30, wound heals most probably. When the basic value is between 10 and 30, provocation test gives information on the wound healing probability. It means that we make another measurement when patient is sitting, leg down, or we use oxygen provocation. And this is a patient where in the left, you can see before vascularization, let's check the yellow probe. So in supine position, the TCPO2 was 22. Then we made leg down measurement, it was 32. And after revascularization, these values were 49 and 61, clear improvement. PAT, pedal acceleration time, it's a new method. It's under investigation, and I hope that we will get soon good information how valid it is in assessment of food perfusion and also healing. It is measured from the duplex curve, and it is the time that is needed to achieve the highest point during systole, starting from the lowest point during diastole. In Helsinki, we have used andesite green fluorescent imaging in patients, and this is you can see the video of our vascular nurse measuring ICGFI. So first you inject andesite green, you image the food with infrared camera, and you can see how the tissue, there is emission of fluorescence. And then in the end, you can draw time intensity curve and make your analysis. What we have used, we have analyzed a lot of these parameters, but mostly we use the maximum intensity. And here we can see a patient who underwent ADP bypass. We can see ICGFI before and after vascularization, and we can see a clear increase in perfusion, both from the recorded images and also from the time intensity curve. And when we measured 104 feet with full wound, we could see during the surveillance that in the regions where wound didn't heal, they originally had much worse increase in perfusion measured with ICGFI compared to the regions where the wound healed. And indeed, 19-unit increase predictive overall wound healing, and better the increase was, quicker the wound healed. Then I go to an algorithm that was published in this document, and I think it is very valid in all patients with a leg wound. So first of all, palpate pulses and examine for signs of ischemia. Evaluate beta Doppler waveforms, perform ABI, TBI to diagnose or exclude PAD. Use 5-5 to stratify healing likelihood and amputation risk. If there is absent pulses, monophagy or absent beta Doppler waveforms, or ankle press less than 100, toe pressure less than 60, consult vascular specialist unless urgent amputation indicated. If ABI is less than 0.4, ankle pressure less than 50, toe pressure less than 30, TCPO2 less than 30, or there is monophagic or absent beta Doppler waveforms, urgent revascularization procedures should be considered and consult vascular specialist. Or if ABI is between 0.9 and 1.3, TBI is over 70, there is good beta Doppler waveforms, persist with wound care and treatment of infection as needed, but reassess perfusion if there is lack of healing progress at 4 weeks. So in summary, in patients with leg ulcer, assessment of perfusion is crucial. PAD is common in patients with leg ulcer. If PAD is not recognized, it delays amputation. It delays the diagnostic, and the delay will increase amputation incidence. It's recommended to measure ABI, toe pressure, and TPI and Doppler waveforms. Any abnormal test results should be considered indicative for PAD in diabetic patients. ABI may be pseudohypertensive, and then you need TCPO2 or toe pressure. And ICT and PAT are promising, but still under investigation. Thank you very much.
Thank you, Marit. That is great. Actually, you have in the chat a group of fans that would like your presentation to share. They've been putting their emails in the chat. I would like to remind everyone who's listening to us that this is being recorded and it will be available most probably in the ESVS library, which is available to ESVS members. So you can become a member. There are loads of very educational videos in our library, and maybe the EWMA will also upload it in the webpage. I guess Kirsi will let us know later. I would also like to tell you that if you want to ask questions live to the panelists, you can write your questions in the Q&A little window that you have in this Zoom, and we'll pick up your questions and ask the panelists. Because you still haven't written any questions, I have a couple of questions for Marit. Marit, when first assessing lower limb wound, if the nurse or the GP clearly palpates a pedal or a tibial, posterior tibial pulse, this pulse is clear, should they stop there or should they still do an ABI with clear distal pulses?
Yeah, that's very, very good question, because the guideline says that if you clearly feel the pulse, there is very, very little chance that there is PAD. However, I always teach our medical students that first of all, you should test that your pulse is not identical with patient's pulse, because many times you can feel your own pulse. And our former professor wanted to always do a test with medical students. He asked a group of 10 to go to the ward to one particular patient and then ask which of the pulses they found. And usually half of the medical students found ADP and ATP from patients that he actually knew beforehand that there is no pulses. So it just showed that it's quite vulnerable assessment. But if you clearly feel, you can even see it sometimes that there is pulses, then it's, but I would recommend to do ABI measurement.
Okay, and if there are no pulses, you've clearly put up an algorithm to go through ABI, then toe pressure, and so on. There are several questions already up there. There is one related to compression, and we'll keep that one for Pablo Ramos, who's going to talk about compression therapy. So don't worry, we're not skipping that question. We're just asking it later when we're talking about compression. There's another question. What about DSA, MRA, CTA, and CFDI perfusion? So that's already imaging perfusion. When does that come in your algorithm?
Well, first of all, if you assess the perfusion with ABI, TBI, and you recognize PAD, then we go for these tests. And yes, if you do some surveillance, as in the last algorithm, if there is no healing in 4 weeks, then we should assess if there is some PAD. So when we clearly indicate that maybe we should do some kind of intervention, then we go for this. But usually the first step is not to go for imaging, but to assess these hemodynamic parameters.
Okay, and I'll ask you one last question before we go to our next presenter. I know there are more questions, don't worry. At the end, we'll pick up all the remaining questions and ask all of the panelists. Just one more before we move on to the next presentation. And this is the question. What is the value of PAT for wound healing prognosis?
PAT. Well, that's a wonderful question, because I happen to know that there are at least a couple of publications submitted but not yet published that touch this question, PAT and wound healing. So which are the threshold values, and is it good in evaluating wounding? I have not myself done PAT. We have discussed a lot that we start to use it also in Helsinki, because we have heard so excited comments about it. So I don't know yet what is the repeatability and what is the how well we can assess wound healing and predict it. But I'm sure that within few months we will get more information about that. So sorry, I cannot answer this now.
Work in progress.
Yes.
Thanks a lot. Marit, don't leave us, because at the end we'll have questions for all the panelists. Now,
Thank
Kirsten,
you.
you're going to introduce our next presenter.
Thank you, Melina and Marit, for the excellent presentation. And now it is my pleasure to introduce you Eva Stürmer, a professor in surgery from University Medical Center in Hamburg. And she is very involved in clinical work in Comprehensive Wound Center, but also leads a research group in translational wound research. And today, Eva will present us and tell us wise words about wound infection. Please, Eva.
So, Kirsi, thank you so much for this nice introduction. I'd be happy to be a part of this panel and of this interesting webinar. And now I hope the technique don't leave me. So you should see. Do you see my presentation? Okay, I switch to full screen. Yes, perfect. So I always start my speeches with this disclaimer, not really with a thing of conflict of interest. You as vascular experts and we as wound experts know how we do our treatment, how do we handle our patient, that we have a multidisciplinary approach for our patient. But in real world, it takes months, sometimes years, till a patient comes to the diagnostic of the underlying disease. And this is our topic we have to refer to. But now let's switch to infections. You never walk alone. Our surface, our skin is covered with billions and billions of bacteria. And if the skin barrier is intact, we have no problem. But if we have wounds, if the barrier is open, we may suffer from infection, and it depends on the individual immune system if we develop a chronic wound or not. And this would be our topic today. I show you the results of two studies. One on the left-hand side was done in Germany, referring to CVI ulcers, and the other one was done in the south of Italy. And what you get aware is that our main enemies, the first three bacterial species you see, are quite the same. And I think it's very interesting that in Europe, we have the same enemies on the wound we have to get rid of, so making our wounds heal. This bacteria also are biofilm builders, but this I will refer later on. How do we diagnose the bacterial burden on chronic wounds? We have three techniques for swabbing and the tissue biopsy to get the information what kind of bacteria are on the chronic wounds. You see the picture of the Levine technique, which is done in 1 square centimeter in the center of the wound, where you may expect the bacterial burden most. And the other technique you see on the picture is the Essener rotary, which mostly is done in Germany. That is a circle on the wound from the center to the wound margin to get aware of all this bacteria. There are two main facts you have to know, you have to refer to if we talk about swabbing and the information about the bacterial burden. One is the tissue biopsy is not superior to swabbing if you want to know what kind of bacteria are on the wounds. And the other one is, and that is the more important one, a positive swab result should never be the indication for the application of antibiotics. We know our skin is covered with bacteria. We know all wounds, even the acute ones, are covered with bacteria, and our chronic wounds as well. So the application or indication for antibiotics is only given in systemic infections and not by positive swabbing results. But if you have a positive swabbing results, maybe you want to know if you have to use antiseptics, or maybe sodium solution is enough for cleansing of the wound. And if you're not an expert, there exist some scores you maybe use to get the recommendation how to deal with your wound. And the Tilly score, as you see on the slide, gives you no direct indication for use of antiseptics. And if you, at your wound, you refer to have more than 5 indirect indications, you should apply antiseptics. And if you have a direct indication like free pus or septic wounds, there is an indication for antiseptics. That is a nice one, but you want to get the information what kind of antiseptics you should use. And there are guidelines for the use of antimicrobials, for the use of wound dressings, all summed up in guidelines for treating chronic wounds. But if you have read this 2 sentences from the German guideline, you maybe shake your head. In wound therapies, we have very, very less RCTs, randomized controlled trials, evaluating different products. So our guideline says there are no conclusion in the benefit of harms of all of our antimicrobials we use in daily clinical practice. That comes to the Zoom that are all the same, they are useful or not. You get no information from these guidelines. Therefore, we tested the different antimicrobial solution we use in daily clinical practice in a translational setting. And I help you to this busy slide. We use on one hand the DIN AN 13727, which is the norm in the approval process of antiseptics. On the other hand, we use in the middle of the graphs wound challenges with coming from patient, from inpatient. We use wound fluid from hip arthroplasty on one hand and swabbing from chronic wound. And the second part is we try to make artificial wound exudate and want to evaluate this antimicrobials from daily clinical practice. And as you see on the left-hand side, we tested Optinisept and PVB-iodine, and all bacteria are killed within minutes, within seconds. The huge bars you see is the concentration of bacteria we have at the beginning, and after 1 minute, both antiseptics kill all the bacteria. On the right-hand side, you see a PHMB solution, and this solution had an efficiency that we all know. It takes a little more time till PHMB kill the bacteria on the wound, and in the norm, that means you have to wait some longer. You have to apply the antiseptics longer on the wound to get rid of the bacterial burden. We also tested hypochlorite solution because there's a renaissance of these solutions in wound therapy. And I show you this 2 hypochlorite solution to inform you that are so different products on the market and used in clinical practice regarding the efficiency. On the left side, you see the Actimaris Forte, very efficient in killing bacteria. But on the right-hand side, you see Granudazine, another hypochlorite solution, which not really kills bacteria, as you can see in the middle of the graph. That means in the group of hypochlorite solution, there are very, very different products working completely different against bacteria. And this is a thing you should know if you apply solution of this group on a wound and want to reach an effect. Because we have no real RCTs or less RCTs in evaluating our daily wound products, we have expert recommendation. In what you can see in this slide is the export recommendation referring to wound irrigation solution. Contamination, colonization, till systemic infection. This is the recommendation what you should use for your individual wound. In the first step of contamination and colonization, you should use sodium chloride and hypochlorite solution. If the bacterial burden becomes higher on your wound, you should use PHMB. And the next step, if it comes from prevention of infection to treatment of infection, there is a recommendation to use octiniidine hydrochloride or PVP iodine. But referring to iodine, you have to say that's brown and that may cover by the color a wound infection. Therefore, it's not really recommended for chronic wound. And the last step and the last decision you have to make is want to prescribe antibiotics. And this is the very, very individual decision of you as a doctor on one hand, and referring to the patient on the other hand. If you have a very ill patient, maybe you recommend antibiotic use more often or stricter than if you have the possibility to control the wound within the next 24 hours. You may be hesitating, so it's a very individual decision referring to you, expertise, and referring to the patient. Which indication is very clear in using antibiotics is a systemic infection. But on the other hand, it's also clear that we not talk about local antibiotics. We only should use systemic antibiotics in wound infection. Local antibiotics, maybe it's a good thing for dermatology illnesses, but not in chronic wounds. So it's not a real breaking news, but I use this wording because it's an old thing. We all knew that very well. If we have signs of a systemic infection, this is the indication for prescribing and an indication for antibiotics, but no other things should be a part of this. But referring to diagnostic, there are some pitfalls in the evaluation of wound infection, in the evaluation in tissue infection in our very old and very ill patient, because comorbidities can suppress signs of infection. On the left-hand side, you'd see a PG, an immunological disease, and you see no swelling, less redness, a very, very terrible wound, but this is not a systemic infection which you have to treat with antibiotics. On the right-hand side, you see a diabetic ulcer, and the patient has very less pain, sometimes no pain. And if you look at the blood results, CRP may vary less, and leukocytosis maybe not really occur in this patient. So be aware of the comorbidities covering infection signs in your wound. At the beginning of my speech, I already have mentioned the biofilm. And referring to the meta-analysis of Malone and co-workers, 78% of all chronic wound, non-healing wounds are covered with biofilm. So in a global panel dominated by American colleagues, says 100% of all chronic wounds are covered with biofilm. I'm not following this because 100%, it's not really the thing clinical practical belief. So I think 78% is a good value, but it's quite often, it's quite frequently in our wound patients. So we have to understand what biofilm is and how we can diagnose it. I show you a clinical picture of a leg ulcer of one of my patients, and you see this wound. The underlying disease is PAD. and you see you see a swollen wound margin. You maybe know by this that there's a huge exudation in this wound. But on the other hand, you see there's a little redness, not really a swollen leg. And if you have a closer look using UV near light, you can identify that this wound is covered with Pseudomonas. By UV light, you can identify Pseudomonas because Pseudomonas build pyroverdines that glow if you stimulate this with UV near light, so you get an idea where the most bacterial burden is on this wound. I show you this patient because you don't really look on the wound surface, you look on the biofilm. This a carpet which is lifting by curette is biofilm. It's not a wound product, it's a product of bacteria. Sometimes you may have found this in your patient, and I'll show you some RAM pictures to get make you aware what biofilm is, to enhance your understanding in biofilm, because most of our chronic wounds are covered with biofilm. These RAM pictures show you the development of biofilm, and the left one is signed by A, is a look on the biofilm as I have lifted on the last picture of the patient. And now in the following pictures, you see the development of biofilm of Pseudomonas in 6, 12, 18, and 24 hours. And on the last picture, you see a white arrow indicating a Pseudomonas looking out of this biofilm matrix. Biofilm matrix is called EPS, extrapolymeric substance, and it consists out of polysaccharides and proteins, which are produced by the bacteria. And it works like a kind of umbrella, a kind of protective shields, because the bacteria in the biofilm are covered with this polysaccharide protein matrix. And you maybe get an idea that it's not easy for our antimicrobials to get into this biofilm and to reach the bacteria, to kill the bacteria inside. But how can you diagnose biofilm on the wound? And there are only some indicators, indirect indicators, because you have not a microscope. You can put not microscopical picture of the patient sitting in front of you and showing you the wound. So there are some, I would say, indicators, marked, maybe show you that biofilm is on the wound of your individual patient. And there is a lack of the response of antibiotic therapy as well as antiseptic therapy, the delayed wound healing, though you're using the optimal local and systemic therapy. And on the other hand, maybe you have negative results and the wound does not heal, though you apply the optimal therapy. It may be an indication for biofilm on the wound. What's now referring, or why referring to this biofilm matrix? And on the right-hand side, you see a graph that shows you why very potent antiseptics fail in killing bacteria in biofilm. You see the Panctonic bacteria, which are very fast killed by Optinisept and PHMB. And on the other hand, you see the graph slightly declined within 72 hours. 72 hours, that means 3 days. And Optinisept and PHMB achieved within these 3 days a decline of bacterial burden in the biofilm. And that is a very, very long time, because in daily clinical practice, antiseptics have to be efficient within seconds, have to be efficient within wounds, and are not allowed to need so much time. And that is the problem referring to biofilm. our antiseptics are not really able to kill the bacteria in the biofilm, so we have to refer to other techniques, to other treatments, and the only one that really works on biofilm is sharp or surgical debridement. That may be a good information, that may be a good news, but we are all surgeons, and there are some publications that say the following things. Debridement is very good, is a good strategy against biofilm, but on the other hand, it is not able to remove all the biofilm on the wound. Therefore, the sustainability is lacking. And if you look at this graph, analyzing the bacterial load on the wound, which was debrided, surgical debrided, what happened to this wound, what happened to the bacterial burden within 24 hours, you get aware of the fact that a surgical debridement reduces the bacterial burden not very extensively. You get loss of bacteria 2 by the power of 10 bacteria, and that's not really much. Therefore, you have to debride the wound more often, and the recommendations say you have to do it again after 48 hours, after 4 days, and maybe another 2 days to reach the sustainability against the biofilm, to get rid of the bacterial burden, and not only one debridement is enough. That is not a really good news, because it blocks your OR if you want really be effective in doing a debridement. On the other hand, there is very important, if you have done the surgical debridement, then you have a window of opportunity of 24 hours for using antiseptics, that they go into depth of the tissue and kill the bacteria in the wound bed and in the wound margin. And after debridement, you have to rinse the debrided wound with very potent antiseptics to make your debridement more efficient. So let me zoom up all the things I have shown you in the last minutes. Bacterial burden is not an indication for antibiotics, and I have to see this by heart, because a lot of my patients have antibiotic and don't need it, really need it, because the general practitioner, I'm not really convinced that a positive swab is not an indication for antibiotics. Maybe that's different in other European countries. You can make your own opinion. Diabetes is one of the comorbidities, covers wound infection very often, and you have to be aware of this fact, because if you send the patient home, they may lose their feet if you not do surgery very in the window of opportunity. That's all said by the diabetic experts. Antiseptics, if you use them, are useful, but they are very different, especially in the group of hypochlorite solution. That is a huge topic, and the manufacturer are not really convinced to make difference, to point out the difference, that we as clinicians really know what their products can do and what not. In the end, debridement is a fundamental tool in wound treatment, but you have to do it more often, not only once, to get rid of all the bacterial burden and to keep the wound in the healing process. With the last slide, I want to invite you to London. I think Kirsi will do it as well later on, because we cover all the topic of chronic wounds, and I think you find things you are very familiar, but in some sessions you get new information, and you'll be inspired if you go home after this Congress next year. Thank you for your attention, and looking forward to see you.
Thank you, Eva, for the beautiful and very profound presentation. And there were many questions in the Q&A and chat as well. We are not able to answer them all now, but we will take some into the discussion. But I will pick up one question here. What was the recommendation on iodine use on chronic wounds? So the use of iodine.
There
what is
are
your recommendation?
Yes, there are two different groups of medical products containing iodine. We have the iodine solution. I would not really recommend for chronic wound because of the brown color. Chronic wounds always tend to develop infection, and if you use a brown solution, maybe signs of infection are covered. On the other hand, we have dressings containing iodine, and they are very useful in the biofilm treatment. I can recommend this one because it's a combined product containing another thing. It is a sugar that's in the product, and that's very useful in fighting against biofilm. So that are my personal recommendation for using iodine in chronic wounds.
Thank you, Evan. If you are able, please be free to answer some questions by writing in the chat and in the Q&A. But now I think it is time to move on. Perfect.
Hello. So now I will introduce Kirsi Isoharanen. I'm probably pronouncing this wrong. She's a specialist in dermatology at the University Central Hospital in Helsinki in Finland. She's an expert in skin cancers and wound care. So Kirsi will be talking about atypical ulcers.
Thank you, Melina. Can you see my slides?
Yep, absolutely.
Yes, here are my conflicts of interest. And first of all, I would like to promote our document. I'm sure very many of you know already. This was published in 2019, and it is still quite updated, and it is a huge information package about atypical wounds. And my presentation will not go so deeply, so that, and I do not think that professionals that are not dermatologists do not have to diagnose these atypical ulcers, but they have to know the typical clinical signs and to be aware when to refer the patient, for instance, for a dermatologist. Just to highlight that these are not so rare. They comprise about 10 to 20% of all chronic wounds, and they are wounds that do not fall into the typical categories. And importantly, and unfortunately, there is often a considerable delay in the diagnosis, which in worst cases can lead to patient's death or amputation. And dermatologists and dermatopathologists are the core persons in diagnosing these atypical wounds. But once the diagnosis is established, then indeed a multidisciplinary approach is needed. And these are the most important clinical clues that when you find in a patient, you should think about an atypical ulcer. First, the wound cannot be classified as a typical one, or the wound has an atypical location or appearance. And there might be a pain out of proportion of the wound size, and also painful skin necrosis is one important sign, because for instance, with venous leg ulcers, there is seldom any necrosis. So if there is very necrotic, painful ulcers, it is very possible that there is an atypical ulcer behind. But of course, you have first exclude infection and ischemia, as already presented by Marit and Eva. And very important, if you are treating a wound and it does not show healing signs with good treatment, that is good local treatment, compression, offloading, within 4 to 12 weeks, you should think again whether your diagnosis is right, whether you should take a biopsy or refer the patient to a dermatologist. We dermatologists see often miserable cases with atypical ulcers that have been misdiagnosed. Pyoderma gangrenosum can be treated with revisions and the wounds enlarged. Melanomas treated as diabetic neuropathic ulcers. Squamous cell carcinomas treated as venous leg ulcers. HS, hidradenitis suppurativa, treated as an abscess, and Martorell ulcers and calciphylaxis treated with immunosuppressants. And that is one learning objective of my presentation, to give some diagnostic clues for these categories. Here is a table of the most important and common atypical ulcers, and you can see that many of them are associated with some comorbidities. So again, we come to this important sentence. It is not just the hole in the patient, it is the whole patient. So, for instance, if you have a patient with inflammatory bowel disease and painful ulcers, you should first think about Pyoderma gangrenosum. We could say that it is Pyoderma gangrenosum until otherwise proven. And on the other hand, calciphylaxis very closely linked with uremic disease and dialysis, and also warfarin medication. I will come back to this later. Usually, and almost in every case, you need a good biopsy taken by a knife, an excisional biopsy. Usually a punch biopsy is not enough because it doesn't go enough deep into the subcutaneous tissue. So you should take a good excisional biopsy from the edge of the wound, so that this skin that is intact is also included in the biopsy, not only the wound bed. So we need epidermis in the biopsy as well. Vasculitis are usually quite easy to diagnose because they are quite dramatic, symmetrical, palpable purpura, necrotic ulcers, and also this livedo racemosa, that is a bluish network around the ulcers. And if you see these kind of ulcers, I'm sure that you are quite happy to send them to a dermatologist, and quite urgently. On the other hand, Pyoderma gangrenosum, a neutrophilic dermatosis, has very many clinical appearances. Sometimes it might be very small, and in more severe cases, very large. Here is a Pyoderma gangrenosum in a leg that was revised 2 times in the operation theatre, and by every revision the wound enlarged. As these Pyoderma gangrenosum ulcers have the pathology phenomenon, they worsen and enlarge by trauma. They often start as a little pustule or abscess, and an important diagnostic clue are these comorbidities: inflammatory bowel disease, rheumatoid arthritis, hematologic malignancies, and metabolic disorder. Here is a patient case of mine from today. Sometimes Pyoderma gangrenosum can be very small but painful, as in here, pretibially in the leg, and you can see these fistulas. We started 8 weeks ago a potent corticosteroid, clobetasol propionate, and compression therapy. That is important also in atypical ulcers. Paulo will show you later. And today I was happy to see that the ulcer had healed. Of course, there was some hyperpigmentation left, but the patient had type 2 diabetes, so I was very happy I didn't have to treat her by oral steroids. Post-operative Pyoderma gangrenosum often also is misdiagnosed. The diagnosis is delayed, as it is typically first thought that this is a surgical site infection, but the wounds do not get healed by antibiotics and revisions. It is most common after breast surgery, but also after other kind of surgery, and there might be some reports of visceral manifestations as well. This is a patient that developed an ulcer that did not heal after mastectomy performed because of a mutation. And sometimes young patients can get also post-surgical PG. This was a 16-year-old girl, and she had rheumatoid arthritis, and she had been operated in the knee area, and an ulcer developed that did not heal by antibiotics, but after the starting of prednisolone perorally, the wound healed. So this was also a post-surgical PG. So if there are some ulcers that do not heal by typical treatments in the operational area, you might think about post-surgical PG and refer your patient to the dermatologist. Livedoid vasculopathy is very often linked with venous insufficiency, but these ulcers are coming every summer again and again, despite compression and despite endovenous surgery. They are very painful, and one typical sign is atrophy blanche, a scary whitish tissue in the feet and toe area. Here you can see more clearly the atrophy blanche. So if you can see this kind of skin in your patients in the ankle, feet, or toe area, and the patient have recurrent painful ulcers, think about livedoid vasculopathy, and the main treatment is anticoagulant therapy with compression. And after that, you can see that the ulcers do not recur anymore. Martorell ulcers are ulcers that might not be so known everywhere. And you can see here that they are also very necrotic, painful ulcers in the ankle, posterior calf, laterodorsal area of the leg, and main comorbidities are hypertension and type 2 diabetes, and also warfarin medication. And the main treatment is surgical revision and grafting. With smaller ulcers, we can do also punch grafting, but we nowadays more and more use also intravenous sodium thiosulfate, as these wounds very often they do not heal from the first skin grafting. They might need several skin grafts, and it takes very much resources and very costly as well. So we have in clinical practice, even if there is no evidence, we have found benefit of this intravenous sodium thiosulfate that is also used in calciphylaxis, but this is a smaller dose with Martorells. Calciphylaxis is a devastating disease with 1-year mortality over 50%, and it is linked with peripheral arterial disease and kidney disease as well. And indeed, here you need a good team with nephrologist, vascular surgeon, plastic surgeon. You can do skin grafting when the process has been stopped with intravenous sodium thiosulfate. And interestingly, we have learned that we should stop warfarin in cases with Martorell and calciphylaxis. And warfarin is also associated with increased internal carotid artery calcification. So there is the same pathophysiological mechanism. Malignant wounds might look as ordinary wounds at first sight. As you can see in this picture, in the upper picture, the patient has venous insufficiency. And at first sight, you might think that this is a venous leg ulcer. But when you look more closely, you have raised borders, and it was a basalioma. And that is why it is so important that you should take a biopsy or refer the patient to a specialist that can take a biopsy if the wound does not respond to your proper treatment. On the other hand, the frightening melanoma can be presented as amelanotic melanoma without pigmentation. This was misdiagnosed as a diabetic neuropathic ulcer, but the ulcer did not respond to offloading. and to good local treatment, and she was referred to us, and we took a biopsy, and it was an amelanotic melanoma. This another case recently, as 87 years old male with an ulcer in the heel and sadly treated as pressure ulcer for 6 months at the primary nursing home, and you can see that the wound was very protuberant. This is not a typical pressure ulcer, this was an amelanotic melanoma as well. And with these atypical ulcers, it is very important to take into account the patient perspective as well, because there is pain, persistent wounds, long treatments, so there is really a reduced quality of life, and increased mortality has been shown also in PG wounds and calciphylaxis. And PG ulcers might be also in young patients, also in children, so it is very important to take into account. And hidradenitis suppurativa that can have ulcers as well, it has been demonstrated by nice studies that there is an increased suicide risk in these patients. So my take-home message is, you do not have to diagnose the atypical ulcer exactly if you are not a dermatologist, but you have to recognize the atypical signs and know when to refer the patient to the dermatologist or other specialist that is capable of taking biopsies and doing the diagnosis. And as I said many times already, if the wound does not show healing signs, you should react to that one. Think again, for instance, if there is a malignancy behind the ulcer. And in successful treatment, indeed, multidisciplinary approach is needed. No one of us can treat these patients well alone. And I also like to invite you to EWMA London, as Eva. Would be nice to see you all there. And thank you for your attention.
Thank you very much for a lovely presentation. Actually, I have a similar experience. I've seen a couple of carcinomas referred to vascular surgery for suspicion of a venous ulcer. And we thought, this one doesn't look very typical. Why is it elevated? And we did biopsy, and there were carcinomas. We sent them over to dermatology. And anecdotally, we also diagnose a lot more calciphylaxis, maybe because we know about it now, we diagnose it more correctly now. And we're diagnosing and treating calciphylactic ulcers in patients without renal dysfunction, without renal disease. Actually, I remember one with whom we learned a lot. He had a primary hyperparathyroidism. So clinically it was calciphylaxia. We couldn't understand why, so we chased it, and we found that it had not been diagnosed. So that is more and more common. You already answered one of my questions, which was time for referral, and you suggested 4 to 12 weeks. There's one question from the Q&A from the audience, and the question is, do the patients with livedoid vasculopathy benefit from treatment of superficial venous insufficiency? So combined venous treatment and treatment of the vasculopathy, livedoid vasculopathy.
Yes, of course, and yes, it is important to send the patient as well to a vascular surgeon or a phlebotomist, depending from your country. I send usually all these patients to my great vascular surgeon colleagues at Helsinki, and we do good collaboration with these patients. It is important to treat all the causes behind. Of course, sometimes they look with the duplex ultrasound. Sometimes they might not be so obvious the cause, but it is important that it is checked also. And very many times they also benefit from the endovenous surgery.
Great, thanks a lot.
Okay, I think it is time to move on, and it is my pleasure to present our last speaker, Paulo Ramos, and he comes from Porto, Portugal, and he's a specialized wound care nurse working in an outpatient clinic, and he's a master in wound care and tissue viability and the chair of the EWMA Education Committee, doing great work in that one, and the title of Paulo today will be compression therapy. The floor is yours, Paulo.
Thank you so much, Kirsi, for this kind of presentation. And thank you all for watching this webinar. It's always good to see that this topic caused so many interest for your healthcare professionals. So related to this presentation, I have no financial interest or relation to disclose. You will see a lot of pictures about system of compression and dressings, but they are what I have in my institution, so no commercial purpose in that too. So the first thing that I want to ask you, if you kindly scan this code in your mobile phone, and I just want to know who is watching us, what is the experience that you have in compression therapy, and how often do you apply compression therapy. To answer this poll, you just have to scan this QR code over here in your smartphone. Hopefully most of you are watching us in the laptop or a personal computer, and after that you will enter in the room, a virtual room, and then you can answer this question. The answers will not appear immediately here on screen. I'm seeing that you are already voting, and in the end, just 1 minute just to let you enter in the room and answer this poll, just to know who is behind the computer, who is in the other side, and to help me doing this talk. It's very important to know the experience that you have. So the question is, how often do you apply compression therapy? Every week, every 2 weeks, monthly? I do not apply, or I do not want to answer the question. So more 30 seconds to help you, or to let you answer this short question. Only 29 persons are answered, so we are moving forward, but I don't have too much time to this pool. So and just to say, I'm sorry because of my vocal situation is not the best doing a webinar, but here in the south of Europe we are used to sun, and now we have 2 weeks only raining, and this caused some damage to myself. So sorry about my voice today, but it is what it is. So we have a lot of answers. Let's see. Most of the participants apply every week. So we have a lot of experienced persons in our audience. That is very good. And some apply monthly, and some do not apply or do not want to answer my question. So thank you so much for your cooperation. I will move forward just to take, oh, sorry about this. Okay, next slide. What is compression therapy? Compression therapy is a basic for treatment the cause of venous ulcer, but not only venous. I could affirm that maybe almost total thickness wounds on the legs, and when we have edema, will benefit with some kind of compression. And how do we apply compression? We apply putting some devices like medical compression stockings, compressive bandages, adjustable compression wraps, or other devices that do or apply a certain dose of compression of pressure in the leg, and we will focus only in the leg today. So to help in what? To help in the reduction of the edema, in tissue remodeling, reduce filtration of fluid from vessels to tissue, so try to improve the blood return and lymphatic return from the leg to the upper body. And of course, with that we have a very good regulations and release of anti-inflammatory mediators. So in the end, it is a therapy that is most useful in the control of inflammation. And we know that most of chronic wounds are chronic inflamed because of biofilm, as Eva mentioned. But if we don't treat the underlying causes, we will have a lot of inflammation. And with compression therapy, we could help solving this. So it's academically is divided in light, moderate, or strong, and very strong. The measures are here. So less than 20 mils of Ag, light, moderate between 20 and 40 mils of Ag, strong more than 40 mils until 60 mils of Ag, and very strong above 60 milligrams of Ag. So this is what is published about the degree of, or the dosage of compression therapy. And of course we have compression bandages. We already approached this, but in this slide we are just have more details about compression bandage, they could be inelastic and elastic, and we could have the combination of both techniques. We could have an inelastic inner layer and an out layer of elastic material, but in the end they will function like a rigid system, because we know that inelastic are better for treating active ulcers at this moment. The compression hosiery or compression stockings are very interesting, but they are mostly used in the prevention of the recurrence of the ulcer, but they could be helpful in small ulcers, and could be helpful too in one aspect that it's not very often mentioned, that is the aesthetic. So a compression hosiery is much more aesthetic compared to compression bandage, or to this last one that is a compression wraps. So that is a fabric, and you use like a Velcro system to secure the system on the leg of the patient, and it's a rigid system too. So these are what I use personally. These are what is documented in the literature, and we will in this talk focus on this system. So we have here some pictures again. We have here compression stockings, the Unaboot ox-zinc bandages, short stretch bandages, cohesive systems, and the wrap system. So this is what I have available in my personal reality here in Portugal, but I think it's almost the same more or less worldwide. So why we need compression therapy? Because when we are resting, usually our venous, because venous are a very large vessel, they increase the pressure. But when we start walking, the pressure should decrease, because when our gastrocnemius contract, it will squeeze the venous system and pull the blood up, and the valves will close and not allow the return of the blood. Okay, that is in a normal person, but when we have valvular incompetency, this is not happen in the same way. So when the blood comes down, the valves don't have enough, this is not strong enough, and opens, and the blood comes down again. So, and cause ambulatory venous hypertension. And this is how compression is so useful, because it will function like an external valve, allowing this system to readapt. When we have valve incompetencies and we put an inelastic system, the gastrocnemic pump will try to will contract, but the system is rigid and don't give any space. So the muscle will squeeze the superficial venous system and the profound venous system, and pull the blood up again, and have these peaks of very high pressure and very low pressure. This is called like a massage effect. The inelastic system have this particular characteristic, that is rigid, and the difference between the walking and standing, or standing and walking, it's more than 10 millimeters of Ag. So it's why we call the static stiffness index. So inelastic materials can improve and reduce the venous reflux, increasing the cuff pumping function, the mechanism that I spoke here, and decreasing the ambulatory venous hypertension. So these are major characteristics. But we have another system that are elastics. Elastics, as I said, like compression stockings or elastic bandage. In my reality, we abandoned elastic bandage, purely elastic bandage. We continue to use hybrid systems that have an elastic component and an inelastic component, but straightly elastic bandage we don't use here anymore. So, but we use compression hosiery or stockings that we put one on the leg of the patient, and the patient will sleep with that stocking, and when he start working or when they start walking, they put in the morning, they put the out layer stocking to achieve the 40 mils of mercury in the ankle. That is what is recommended. But this system, because it's elastic, when the cuff pump start to working, when we are walking, the system gives some space, and it's not so effective in the venous reflux. So this material is a good one, continues to be helpful in our clinical practice, but mostly we use to prevention of the recurrence and to treat some small ulcers. So the effectiveness, I think I already touched all these points here, just a brief resume. So we use modified compression therapy using short stretch material with a pressure of 40 mils of Ag is very effective in obtaining healing of mixed ulcers. This is a new finding. So even when we have an arterial component, if it's not critical ischemia as the first speaker approach, so we have completely secure that the arterial impairment do not impede us to put the leg of the patient under compression, but we adapt 40 mils or less than 40 mils, 20 to 30 mils in the case that we have slow ABIs or low ABIs, not slow, sorry, low ABIs. And of course, members with critical ischemia should not have any compression at all. And of course, we must be aware that patients should be engaged with us, and we should try to explain disadvantages to the patient for better compliance. These guidelines, they are the ESVS, the new guidelines that was published last year. And I just want to focus because they are freely available on the web. But just to highlight some new recommendation, and I think the most important one is this one, the recommendation 74. For patients with a mixed ulcer caused by coexisting arterial and venous disease, modify compression therapy under close clinical supervision, and this is very important, with a compression pressure less than 40 mils, but we could achieve 40 mils in some cases, but if we have any doubts, less than that, may be considered provided by ankle pressure higher than 60 mils. So this is, I think, one of the most interesting new evidence that we have, and as I will show later, some cases about this. So I think the main indications are here summarized too. So inelastic for treatment of the active ulcer or very severe cases of edema of leg, like if lymphedema or lipedema, and of course the elastic systems more for prevention and small ulcers. Another thing, it's now I will try to be more interactive with this part of my presentation. One of things that I sometimes we listen is applying compression is too workly. It takes a lot of time. So in this quasi-experimental studies, like a funny that this guy André Vaz, that is a very skilled nurse here in compression, he do some application of short stretch bandage. This one is about a kit that is already prepared, and this one it's a garment. You take the measure, you will cut the garment and apply, and the last one is compression stocking. So here we see the time that in the end he spent in the application of different systems, and we can see that it's not too much time, and I think the patient will thank us if we do properly the compression and apply compression, because the results are very, very good from our patients. So let's move on. So in my personal perspective, it's not too time consuming, it's a myth. So it is possible to use adjuvant therapies with compression. Yes, it is. You could use, for example, negative pressure wound therapy. The only care that I suggest is put the device that is collecting the fluid to the reservoir of the device, not over the ulcer, but just a little bit up, and please use extra padding material for not cause pressure injuries on the patient. And here we are using electrostimulation that is very interesting, results in the very painful ulcers, and we could apply with minor changes of the kit, and it's possible and could be helpful in these cases too. And how about foot ulcers that are linked to venous ulcers? So it's necessary to apply compression therapy here. Even if we have foot ulcers in the dorsal part of the foot, it is necessary to apply compression, and the healing will be much more faster if you apply compression compared to not applying compression at all. So if you have a foot ulcer and the patient it's caused by venous stasis or venous hypertension, apply compression, you will achieve better results with that, no doubt. And of course, as I said, sometimes you use compression ulcery or compression stockings. It's very interesting. Small ulcers, as you can see here. The patient have some concerns about the bandages. She don't like that we bandage the legs, so we propose compression stockings. She accept, and again, it was healed very quickly. 7 weeks, and it's done, and the patient was happy, and we were happy too, because the results were achieved in very short time. And again, a patient with an active leg ulcer should not work. Sometimes we listen to it. Of course, in an ideal world, the patient should rest the leg elevated with the leg, should rest with the leg elevated. But we are not in a perfect world. And I work with some populations with very poor economic status. So this patient with these 2 severe ulcers want to continue working and just want to come to the clinic once a week. It's very difficult, but fortunately we have very good systems that stay in place. If you can notice here, this system was applied and in 30th of October 3 years ago, and in the 6th of November it's the same system. It works every day standing. So walking and in the workplace, and the bandage stays in place. And of course, it takes a lot of time in these cases, okay, but the patient could continue work. We of course address the pain of the patient, and of course try to improve some lifestyle, but it's possible to, even when patients are working, achieve the completely healing of the ulcers with proper compression. And of course, on patient with mixed venous arterial ulcer, very severe ulcers, very painful ulcers, it's possible. Yes, it is. And in this case, I recommend, it's not in any guideline, but in my clinical experience, usually I am more tendency to use this kind of compression system. And why? Because I could dosage the pressure that I'm applying on the patient. So, and bandages sometimes could be I could cause more pressure injuries using bandage, even with a correct padding, compared to a wrap system like this one. And you can see here, this is a pressure point, but I think this is not because of the wrap, it was because of the shoe of the patient. This, we can see the evolution, okay, it's improving. This takes a lot of time. The exposed tendon is now recovery by granular tissue, and this was a picture, okay. We have here a very good result, and we can see here now, this picture is from today. This patient is now in the end of stage of the treatment, so in 28 weeks, okay, it's a very long time. But the patient have 89 years old, anemia, very fragile patient with a very impaired mobility too. So I think it's a good result, and the pain decrease, and the patient gains some quality of life with compression. Eva focused about cleansing and debridement, and here it's important when you have a very oversized leg with a completely unhealthy wound bed. It's important to cleanse, like I'm cleansing here my garage entrance after the winter. We need to cleanse, and after that we will achieve a proper wound bed to apply the wound dressing that I want. And after that, extra padding. And of course, this patient is a very obese patient, a very large leg. Normal kits, it's not fit, do not fit to this patient. So we have to use short stretch bandage, and we increase the stiffness of the system, put in more bandage, because he rides bicycle in his everyday living. So we put four short stretch bandage. And as you can see here, this is just a comment about the superabsorbent dressing. It's not important from this for this specific topic we are discussing today, compression therapy. But of course, we see 10 weeks of follow-up and the ulcers, just small points of unstable epithelium, but as you see here, and of course, for prevention of recurrence, because the very obese patient, and to prescribe a stocking to this leg, it should be a nick, a flat nick one, and it's very difficult to putting on that kind of stocking. So we recommend the system, the wrap system, and the patient have opportunity and is now with this one to prevent the recurrence of the ulcer. Of course, sometimes very fragile patients stay a lot of time with the leg down in the sofa, in the couch, and sometimes they call us in home care to evaluate the situation. And of course, we put a corticosteroid skin bandage or use a wrap system. We take off the edema and the lesions will heal naturally. So very important. And of course, it gives a lot of quality of life of this lady that at the time was 95 years old. So important. Compression therapy gives quality of life. And sometimes colleagues send some very, very impressive photographs. And in this photograph, the point that I want you to mind is this one, sanitary pad and shoe of the patient. So this is extreme leakage ulcer, and it have a huge impact on the quality of life of this patient. So we need to address this. We need to cleanse, debride, treat the surrounding skin, and with proper care, compression therapy always. And of course, with that we will achieve the complete healing. Sorry, it's this one slide. We achieve with 31 weeks of follow-up, we achieve the completing of the ulcers. No antibiotics during this process, only cleanse and debridement, use of some antiseptics on the first part of the treatment, and we achieve this result in the home care specific. But when we have infections, is compression therapy should be put on the table to infected situations? Yes, it could be a possibility. In this case, a very recent one that we have in my unit, we have a huge blister here. We debride this blister. We see that the patient was an inpatient in hospital for 8 days doing IV antibiotics, and he returns home with oral antibiotics and then came to us to proper local treatment. We debride, cleanse, debride, antimicrobial at the first time, compression therapy with an inelastic kit. And we can see here just a few days, a huge improvement before cleansing and after cleansing the area. And again, 16 days we have, and of course this lady should use a compression stocking to prevent the recurrence of the erysipelas. And of course, after we do the treatment to the ulcer, after we remove the bandage or remove the system that we are used to treat the ulcer, it's important to continue compression. So to avoid this kind of situation, it is a discompressed syndrome. But again, we put this leg under compression. It's not a vasculitis, it's nothing atypical, but we put the leg of the patient under compression. And again, she understands now that she must use compression for the rest of her life, of course. Just some practical tips. I'm just ending now. Apply multi-component multilayer inelastic bandage or wraps to treat. Inelastic bandage with full stretch, not painful, but when correctly applied. But in my personal reality, I do not use elastic bandage. Only use inelastic or like hybrid system, as I referred earlier in this talk. Padding, it's very important, especially in bone prominence and tendon prominence, and of course, do not forget when we are using, for example, negative pressure wound therapy with compression therapy to avoid that the system could harm the patient too. Avoid strong pressure in the legs with acute tibial crease when patients are some patients have a very acute tibial crease, so be aware of that. And of course, strong pressure in these ulcers, but we can dosage the pressure with systems like the wraps and could be very helpful in our clinical practice. Some formal contraindication, allergic. I never saw an allergic reaction to compression therapy, but it could be. It's a formal contraindication. Critical limb ischemia, severe neuropathy, severe heart failure in the New York scale, stage 4, and extranatomic bypass. They are very few contraindications, and they are rare and uncommon. And sometimes we have some side effects, as I mentioned in this slide. I wrote side effects. This first one was provoked by me with a bandage. Sometimes the bandage slides a little up and down, and it could happen. And this one is a patient that decided to apply himself the short stretch bandage that he had at home, and it was not the correct way. So some take home message. So compression therapy, it's a very good treatment. It's widespread modality for chronic venous disease, but it's applicable in a lot of other conditions to be to help us solving some of the most serious wounds on the lower legs. Its efficacy is frequently underestimated and neglected. That's why it's not so widely applied. But it's a very effective treatment, and we could control pain with compression therapy. We could give a lot of quality of life to our patients. And education, it's necessary, but it's necessary not so educated. It's to train and to implement. I think the most difficult part is train and implementation. And of course, we have a lot of different systems. We could use all, but we should have some guidance to that. And so elastic compression stockings could be helpful. Of course, elastic or inelastic bandages are very helpful, and compression garments, yes, they are very helpful and could be less susceptible to human factor. When you apply a compression garment, you follow the instructions, is very intuitive. So I'll leave you with my contacts, and even when go to long journeys in my bike, I use my compression stockings because it helped me a lot, because the engine give a lot of hits in my legs, and of course it helped me to prevent the edema. So thank you so much. I hope I will be available to pass the message, and of course I'm available for questions or comments. Thank you so much.
Thank you, Paolo. You really delivered the message very well, and thank you for your sharing your profound expertise. Very highly appreciated, and there are many also congratulations in the chat, and we have time for one question. I think this is important to cover. So leg edema, cellulitis, and blisters due to heart failure. Is it an indication or contraindication for compression therapy? You already said something about, but I think it is important to highlight again.
As I mentioned in the slides, of course, when we are a very end stage of heart failure, no, of course, it's not possible to put the pressure compression on the patient, because it will increase the overload of how the heart will overload the heart. But until stage 2, maybe stage 3, New York class, it's possible to compress. But another thing that I've been saying, if you have doubts, go slow, small baby steps, start to compress gradually, and you will achieve the treatment. Sometimes we don't have to put so much. For example, when you have mixed arterial patients, I don't put 40 mils of Ag initially. Why? Because that skin is more prone to pressure injuries. So I put 20 and try to go further. If not possible, I stay in 20, and usually it's enough. The cellulitis. In the acute phase, there is a point of debate at the moment, but the patient that I mentioned already passed the acute phase. She was 80 days in the hospital, and then came to me to continue the treatment. And after that, she was a very young lady, 28 years old, I think. So she have kids. She needs to do some homework, and she needs to walk. So compression is the best way to prevent the edema and to prevent that blister to become a chronic ulcer.
Thank you, Paolo, and thank for all the attendance from my side. One reminder that we do not share the slides, but this is recorded and can be found at EWMA website for several months, and for the certificates, the persons that have been attended over 70% of time will get the certification. This was great, and we got a lot of congratulations in the chat as well. And now I will hand over to Melina for the final conclusion words.
Well, as I said before, it's been a pleasure for ESVS to co-host this EWMA webinar with you. It's been wonderful to be with you this afternoon for a short while. I've learned a lot from all the panelists, and as some of the people commented in the chat, it has been very useful for our daily practice, because it is true, this is the kind of patients we find in everyday practice. So thanks a lot, and see you soon, hopefully. Have a great week.
See you soon. Thank you so much for being here.
Thank you.
Thank
Bye-bye.
you. Bye-bye.
Bye.